Hello, my name is Quentin Broussard. I am Assistant Professor of Clinical Sciences at California Health Sciences University, and today we will be discussing status epilepticus. The reason we're discussing status epilepticus today is because status epilepticus is a medical emergency associated with high morbidity and mortality. After first and second line therapies, there's limited data to determine the most appropriate treatment approach to how to treat status epilepticus, though there is some limited data. As a pharmacist, it's important to be aware of agents used for status epilepticus and what roles they play in the treatment of status epilepticus. So our objectives today will be to classify the types and stages of status epilepticus, to differentiate status epilepticus versus epilepsy, and we'll talk a little bit more about this on day 2 of our status epilepticus TBL session. Compare and contrast treatment options for status epilepticus, discuss status epilepticus primary literature, and review considerations for treatment of status epilepticus in selected populations such as pediatrics, geriatrics, and pregnancy. So we'll start off with a patient case. AI is an 80-year-old male presenting to ED initially with altered mental status. After about 2 minutes into his ED visit, he develops a visible, uncontrolled, generalized convulsive seizure that lasts for about 5 minutes. He has no relevant past medical history. Which of the following is a first-line pharmacotherapeutic agent that can treat AI seizure? Is it Phenytoin, Lorazepam, Levetiracetam, or Valproic acid? Next question. AI was provided with first-line pharmacotherapy in the first question to treat his seizure. However, his seizure did not resolve. The healthcare team decides to give another agent to abort AI seizure. 15 minutes into infusion of this second treatment, AI's blood pressure decreases from 112/82 to 70/46. If chosen as treatment, which of the following pharmacotherapeutic options is most likely to cause this hypotension? Is it Phenytoin, Fosphenytoin, Levetiracetam, or Valproic acid? And the third question, despite treating AI with 2 abortive medications, AI is still seizing. It has been 30 minutes since the beginning of his seizure. Which of the following types of status epilepticus does AI have? Is it generalized convulsive, non-convulsive, refractory, or does AI have epilepsy? So after today's discussion, you will be able to answer each of these questions confidently. In terms of the definition of status epilepticus, the definition of status epilepticus is highly debated, even among status epilepticus experts. In general, status epilepticus can be defined as prolonged seizure activity. Now, what does prolonged seizure activity mean? Some definitions of status epilepticus may indicate that status epilepticus has to last for at least, or a seizure has to last for at least 5 minutes before being termed status epilepticus. In the American Epilepsy Society, they define status epilepticus as continuous seizure activity, or as 2 or more seizures without full recovery of consciousness between seizures. In regards to status epilepticus epidemiology, status epilepticus affects about 50,000 to 150,000 Americans annually, and about 10 to 41 people per 100,000 worldwide. It costs about $4 billion annually in the United States regarding the health care cost associated with status epilepticus, so treatment, hospital stay, and potentially even more money whenever the patients actually get out of the hospital if they need supportive care after. Status epilepticus is associated with substantial morbidity. So as I just alluded to, patients that have status epilepticus, may not be eventually able to do the same things that they were able to do prior to their status epilepticus episode, depending on how long status epilepticus lasts, with shorter periods being associated with better outcomes and longer periods of status epilepticus being associated with more poorer outcomes. That can be a big determinant of whether or not your patient will have a meaningful life after their status epilepticus incident. It is the second most fatal neurological emergency, the first most likely being stroke. And in regards to ethnic populations versus Caucasians, it has a higher incidence in ethnic populations versus Caucasians, with about 57 people per 100,000 being affected in ethnic populations and 20 people per 100,000 being affected Caucasian-wise. It's important to note that about 54% of cases occur without an epilepsy diagnosis. And this is important to realize. In order for a patient in regards to status epilepticus, you do not have to have an epilepsy diagnosis beforehand. So these patients may develop status epilepticus as a result of some kind of acute injury or some kind of acute event, as we'll talk about in the etiology of status epilepticus a little bit later. And it's important to note that status epilepticus may be the first sign that a patient actually has epilepsy, though just because a patient has status epilepticus, it does not necessarily dictate them to have an epilepsy diagnosis. That's important to know about. We'll explain that a little bit later. Regarding the pathophysiology of status epilepticus, it's poorly understood, but what we do know is divided into stages or phases. It's important to note that there's no set time for each stage or phase. So throughout this presentation, I'm going to mention a lot of different time periods where certain events are occurring. And this may be mechanistically through the pathophysiology of status epilepticus, which we'll talk about on the next slide, or even regards to the stages of status epilepticus, which can last anywhere from seconds to minutes to even hours. It's important to note that there's no set time for any of these. The times that will be on these slides are just to give you a little bit of context of how long they typically last, but it's not set for every single patient. In regards to status epilepticus, it's believed that there is a failure of endogenous mechanisms to abort the seizure, such as those exhibited by the neurotransmitter GABA. And if we remember from pathophysiology, GABA is associated with an inhibitory response, and as a result, a depression or cessation of actions. Comparing that to other excitatory mechanisms, such as those that are associated with glutamate and the NMDA receptor and the AMPA receptor or AMPA receptor, you may have in status epilepticus continuous excitatory mechanisms to sustain the seizure. So either there may be a failure of inhibitory processes occurring in the brain, or there may be continuous excitatory processes in the brain that cause status epilepticus to continue or the seizure to continue. We see a little bit of that whenever we look at the pathophysiology breaking down in time references. And again, these time references aren't necessarily concrete for every patient. So you see under stage what is considered 1, under milliseconds and seconds, that protein phosphorylation, ion channel opening and closing, and neurotransmitter release occur. The part that I want to emphasize on this slide that's very important to be aware about is in the seconds to minutes phase, where we have different receptor trafficking mechanisms that occur. So whenever a patient presents in status epilepticus, it's believed that you may have a decrease in inhibitory GABA receptors, as well as an increase in excitatory NMDA receptors and excitatory AMPA receptors. And this is important to note because a lot of our drugs that we use to treat status epilepticus are targeting these different receptors here, either to agonize them or antagonize them. And so you see here in this step that you have a decrease in certain receptors, the inhibitory receptors, and an increase in the excitatory receptors. And these mechanisms play a big role in regards to which agents we pick when we treat status epilepticus. We also have different mechanisms that occur at the minutes to hours phase and the days to weeks phase. In the minutes to hours phase, we have neuropeptide expression, so increase in excitatory substance P, insufficient replacement of inhibitory neuropeptide Y. And in the days to weeks phase, where status is prolonged, you may have genetic and epigenetic changes, such as gene expression, DNA methylation, and regulation of microRNA. The seconds to minutes phase, or the stage 2 phase, is the most important part for drug therapy. So basically, the point I'm trying to get out with this slide is that the longer that you wait to treat status epilepticus, the higher likelihood that status epilepticus will continue to occur because of these proposed mechanisms here. Doesn't necessarily mean in every patient that status epilepticus will continue. We do have drug and pharmacological therapy that can help treat status. But status epilepticus treatment is not always a guarantee to stop status, as we'll see when we start talking about the different medications and the different stages in regards to time. In regards to status epilepticus, it can be an acute or a chronic process. It's more so associated with being acute. However, whenever you actually think about the pathophysiology of status, though some patients may just chronically be in status epilepticus or going in and out of status epilepticus. It can be considered type 1 or type 2. Type 1 being associated with no structural lesion in the brain versus type 2 being associated with a structural lesion. And we also have pediatric and adult populations that are affected. So practically anybody in any patient population can be affected by status epilepticus, whether it's children or adults, as well as pregnant patients, which we'll talk about a little bit later. In regards to status epilepticus, we see here that those acute and chronic causes of status. So a lot of the acute causes have to do with some kind of effect on the brain. So if you think about a lot of our neurological disease states, such as stroke, such as that caused by trauma, such as traumatic brain injury, which we talked about a couple weeks ago, those things can propagate an insult of status epilepticus to occur. Other things that we may see are metabolic abnormalities. So this can be anything from low sodium, high sodium. It can result from hypoglycemia, so low blood sugar, hypoxia, a systemic infection such as that encountered in sepsis, though not necessarily all systemic infections will cause status epilepticus. Anoxia, or loss of oxygen to the brain, trauma, as we just alluded to. Drug overdose is a very common presentation of status epilepticus. CNS infections, such as that encountered with meningitis, and a CNS hemorrhage, which may also be associated with traumatic brain injury. We also have chronic presentations of status epilepticus that can occur, such as those relating to low concentration of anti-epileptic drugs. So particularly those drugs that require a therapeutic drug concentration. And some examples of those that we'll talk about are Phenytoin and Valproic acid specifically. But it can be any anti-epileptic drug that requires concentration or serum concentration monitoring. You may have some symptomatic causes that may cause status epilepticus, such as tumors, particularly those that are in the brain, but almost any tumor can cause status epilepticus depending on the nature of that tumor. Stroke and trauma. Alcohol misuse. So this can be from either alcohol overdose or even alcohol withdrawal. And that's an important concept to think about. And you'll talk more about alcohol withdrawal with Dr. Wang in a few weeks. Again, tumors. And then you may have idiopathic causes. So idiopathic just means that we don't necessarily know what the cause is. And in some of those cases where we have those idiopathic causes, where we don't necessarily know what the insult is, those patients may later on be diagnosed with epilepsy. However, you may eventually develop epilepsy as a result of any of these. So just because you have an acute presentation doesn't mean that you cannot develop epilepsy after that acute insult to the brain. In regards to classification of status epilepticus, it's broken down into a few different classifications. Generalized convulsive status epilepticus, which I like to think of as associated with actual visible convulsions. Non-convulsive status epilepticus, which we traditionally think of as with no convulsions, though you may have some minor subtle status, which we'll talk about. Refractory status epilepticus, and epilepsy, which again is a chronic disease state. So in regards to GCSE, or generalized convulsive status epilepticus, it is associated with convulsions associated with rhythmic jerking extremities. Most likely seen or most associated with tonic-clonic seizures. Patients may, in any kind of seizure, present with impaired mental status, and that can be confusion, lethargy, or coma. And you may have focal neurological deficits in the post-ictal period. So basically, after this patient presents with their status episode and their seizing, after their seizure episode, in the post-ictal period or the post-seizure period, you may have some neurological deficits that may occur. Now, sometimes those deficits may be temporary, depending on how bad the seizure is and how bad the severity of the status epilepticus is. Those may be permanent. So, important thing to realize with GCSE, or generalized convulsive status epilepticus, it involves convulsions associated with visible rhythmic jerking extremities. The next type of status we'll talk about is non-convulsive status epilepticus. So it's essentially what it sounds like. It is non-convulsive. Typically, you can only see the seizure activity on an electroencephalogram, or EEG. And typically, it's associated without clinical findings of GCSE. Typically, there are two types of non-convulsive status epilepticus. One is considered the wandering confused patient, where they don't exactly know what is going on, so they essentially appear altered, but again, without the clinical findings of GCSE. And then the other type of non-convulsive status epilepticus is an acutely ill patient who has severe altered mental status with or without subtle motor movements. And that is what is considered subtle status. Now, in regards to the classification of non-convulsive status epilepticus and convulsive status, or generalized convulsive status epilepticus, this is the part where debate may occur, because patients that have subtle motor movements may actually be considered generalized convulsive status epilepticus. If you are asked this question on an exam to differentiate generalized convulsive or non-convulsive status epilepticus, it will be very obvious. Again, I consider non-convulsive status epilepticus to be without clinical findings of generalized convulsive status epilepticus, essentially no convulsions. So if they're having any kind of motor movements, it's more likely to be generalized convulsive status epilepticus. Though you can have some cases where you may have subtle movements, just very, very subtle, where you may be considered non-convulsive status epilepticus. In regards to the diagnostic workup of patients who have status epilepticus, all patients should get a finger stick glucose and vital signs taken immediately upon admission to an ED. Finger stick glucose, because obviously one of the big causes of status epilepticus may be hypoglycemia. Vital signs in case that we need to treat, hypertension or hypertension associated with status epilepticus or some other type of disease state. Head CT should be done in most cases to evaluate for any type of brain injury or even stroke. Laboratory tests should be done, such as a CBC, BMP, ionized and total calcium, as well as magnesium level. And you might even consider a phosphorus level as well, since it's not on the traditional BMP. Other things that you might want to consider whenever working up a patient who initially presents with status is that you may eventually get an MRI on these patients to get a little bit better imaging of the brain. You may take an LP, particularly in those patients who have meningitis. An LP is essentially just taking out some of the CSF fluid to evaluate it for a CNS infection like meningitis. And remember, that's one of the acute causes of status. You may also take a comprehensive toxicology panel, depending on if you have any inclination or history that a patient may be taking an agent where a seizure may occur, such as those associated with overdose. So isoniazid, which is a drug that's used traditionally to treat TB, tricyclic antidepressants, theophylline, cocaine, other sympathomimetics, alcohol, organophosphates, and even cyclosporin, which is traditionally used for transplants or post-transplant care. Some other laboratory tests that you potentially want to take are LFTs to evaluate for liver function, because there are some drugs where we don't want to give in hepatotoxicity specifically. Serial troponins to evaluate for any cardiac disease such as MI. Coagulation studies to assess for things such as thrombocytopenia, which may contraindicate or limit the use of certain drugs like valproic acid. ABG might want to be obtained. An important one to obtain are AED levels, so anti-epileptic drug levels, particularly if a patient has been on an anti-epileptic drug and you know about it. So say if a patient came in who was on an anti-epileptic drug such as phenytoin, valproic acid, carbamazepine, which has serum levels that have to be therapeutic in order for the drug to work, or potentially be therapeutic for the drug to work. Because remember, just because you're drug levels aren't therapeutic doesn't necessarily mean that the drug is not working. But the thing I want to get at here is if your level is, low, you might want to actually consider bolus doses of the medication in question, IV, or even sometimes PO, you might be able to get away with. Most likely IV in status epilepticus, though, to try to get you back to a normal therapeutic serum level. Another thing that we might want to evaluate for is inborn errors in metabolism, and essentially this occurs with the metabolism of urea and ammonia. So some patients may not be able to metabolize ammonia properly into urea, and that may actually predispose patients to developing seizures and status epilepticus. And those disease states are known as inborn errors in metabolism. In regards to monitoring status epilepticus, one of the biggest monitoring parameters or monitoring tools that we can use to monitor status epilepticus is a continuous EEG or electroencephalogram. Another thing that we want to watch for is resolution of visible seizure if the patient has GCSE. So remember, again, GCSE, visible seizure, NCSE, most likely a seizure that can only be diagnosed with continuous EEG. We want to monitor medication levels depending on the medication if they have a serum level that can be obtained. We want to monitor vital signs. We also want to monitor, if applicable, intracranial pressure, as we've discussed before with traumatic brain injury. Depending on if the patient has a traumatic brain injury and they present having a seizure or status epilepticus, ICP monitoring will also be very, very important. In regards to electroencephalograms specifically, or EEGs, essentially EEG, the EEG or the essential device that helps us kind of monitor brain function of a patient essentially looks like this when applied to a patient. So there are multiple electrodes that you see here that are attached to the brain. And as a result, these electrodes will transfer data to an EEG, what is known as an EEG reading. Now, as a pharmacist, it's not necessarily important to know how to read an EEG, but you should know a few things about some of the components of an EEG, which we'll talk about on the next slide. EEG should be used in patients who remain unconscious after the initial therapeutic agent. If you're receiving long-acting paralytics, for example, so if you're getting, a Nimbex drip, and we want to monitor your neurological function because it's almost impossible to with paralytics on board, then we get an EEG. And those who are requiring prolonged refractory status epilepticus therapy. And what I mean by refractory status epilepticus, as I briefly mentioned on the types of status epilepticus slide, is that refractory status epilepticus is essentially status epilepticus that is prolonged or is refractory to multiple status epilepticus therapies. So say if you've given 2 agents for status epilepticus and you're still having status, that diagnosis at that point is best to call it refractory status epilepticus, since you've tried to treat it with multiple agents and it's been prolonged. Therapy or pharmacotherapy should not be delayed while awaiting an EEG result. So if you have a patient who's in status, you need to give them some kind of medication immediately. Don't wait for the results of an EEG to occur, because at that point you're doing more damage to the patient or more harm to the patient than benefit. That seizure needs to be stopped, and anything that we can do to stop the seizure is beneficial. Just a little brief background about what is looked for on an EEG. So one thing that neurologists and neurosurgeons may look for when evaluating an EEG to assess whether or not a patient's status epilepticus has seceded is what is called burst suppression. And what burst suppression is, as we see here on the left side, these little highlighted portions are essentially what are called bursts. So you see lots of little squiggly lines here. That's essentially activity that may be considered or associated with status epilepticus. When you have these long lines of what is termed burst suppression, that essentially means that there may not necessarily be any more status epilepticus or epilepsy activity at that point. And as a result, you may eventually, after seeing this burst suppression for about 24 to 48 hours, you may titrate down anti-epileptic medications, which we'll talk about when we talk about de-escalating therapy. In regards to the prognosis of status epilepticus, there is a 20% overall mortality rate, which is relatively high whenever you consider other disease states. And outcomes are worse when the seizure is prolonged. So seizures lasting greater than 30 minutes are less likely to spontaneously abort. Due to the pathophysiological theories that we discussed earlier with the GABA receptors, the NMDA receptors, and the AMPA receptors. And higher mortality with seizures lasting greater than 30 minutes as compared to less than 30 minutes. So essentially think about the brain activity and what is occurring during that time. If you have a patient who's in status epilepticus, time is of the essence. And the longer the seizure lasts, the higher rate for morbidity and mortality. The cause is the most important determinant in assessing the mortality risk. So, for example, a patient that has a traumatic brain injury may be at higher risk than a patient that has some mild hypoglycemia, though that doesn't necessarily mean that all patients who have hypoglycemia will make it out okay from status epilepticus. The cause is the most important determinant in assessing the risk, but it's also the most important determinant in determining the treatment, because ideally we want to try to treat the underlying cause if possible. So if it's hypoglycemia, we ideally want to give them glucose. If it's traumatic brain injury, we want to ideally minimize the complications of that traumatic brain injury. We may do brain surgery. We may evacuate hematomas. We may do other things to minimize the risk. There's a score called the Status Epilepticus Severity Score, or the STESS score. And this is not necessarily something that you need to know for exam purposes, but it's just a tool used to predict the mortality from status epilepticus. In regards to goals of therapy for status, the goals of therapy are to abort physical and electroencephalographic or EEG evidence of seizures. We also want to identify the cause of status epilepticus, prevent the recurrence of status epilepticus if possible. We want to minimize adverse drug events by picking proper pharmacotherapy for patients, and we want to treat complications of status epilepticus. So whenever we have a patient who comes in with status epilepticus, we have a few goals that we want to achieve first. The first thing, obviously, that we want to do when a patient comes in with status epilepticus, or if they're already in our care and they develop a seizure, we want to make sure that we stabilize the patient. And that can be anything from airway, breathing, maintaining circulation. In addition, we want to assess the time of seizure from its onset and monitor vital signs. So we want to watch how long the seizure has been occurring, because again, longer seizures may be associated with poorer outcomes. We want to assess oxygenation and give oxygenation via nasal cannula or mask, or consider intubation if respiratory assistance is needed. So if patients present with status epilepticus, they may not necessarily be thinking to breathe. They may not actually necessarily be thinking necessarily at all. And that's something important to realize, that these patients don't necessarily have control over their bodies. And one of those things that they may not necessarily have a control of is their respiratory function. Even though breathing is typically a passive process, sometimes those passive processes can kind of diminish whenever a patient's in status epilepticus. So a lot of times what will happen in status epilepticus is that these patients will actually be intubated, regardless of whether or not they have respiratory issues or not, particularly if they have longer incidences of status epilepticus. Doesn't necessarily mean every patient will be intubated. It just means that if we see that there's a problem and this patient continues seizing, the physician will most likely intubate rather than not intubate, because they want to, what is termed as, protect the airway. We want to initiate EKG or ECG monitoring. So we want to get an idea of the heart function. So does the patient have any arrhythmias? Do they have any cardiac issues? So note that it's ECG monitoring here, not EEG monitoring. We want to collect a fingerstick glucose. And if the glucose is less than 60, per this guideline here by the American Epilepsy Society, or less than 70, which is what some clinicians will use, then you can go either down two paths. For children, we will just give them dextrose, essentially. And you see the doses here. These are doses that you don't need to necessarily memorize, but you just need to recognize that if it's a child, we will give them dextrose. Now, adults are a little different, because one of the things that we want to assess for whenever we have anyone come in is that fingerstick blood glucose. If their glucose is less than 60 or 70, with adults, there is always a risk that the patient may have had some alcohol consumption occur. And usually the blood glucose stick is always the first thing that we check. It will probably take a little bit longer for you to get the result back from a toxicology panel, which can include a blood alcohol level. So whenever a patient comes in, you're not necessarily going to know whether or not they use alcohol or not. And the reason that this is important to be cognizant of is because these patients, particularly those who use alcohol and those who may be withdrawing from alcohol, may take an anaerobic metabolism pathway after glycolysis, which, remember, glycolysis is the process by which glucose is converted to pyruvate. Pyruvate is then shunted through a process and eventually goes to the TCA or Krebs cycle to make more energy. In patients who have alcohol withdrawal or may be ingesting alcohol, that process, when going from pyruvate to Krebs cycle, may actually be shunted away from the Krebs cycle to the anaerobic metabolism or lactic acid pathway. In that pathway, you are not necessarily creating as much energy, and you're actually being anaerobic in the ways that you function. What thiamine does for patients is it actually shunts that metabolism from the anaerobic pathway to the aerobic pathway of the Krebs cycle or the TCA cycle. Therefore, for any adult that comes in with a low blood glucose, we will give them 100 milligrams of thiamine first. Then we will give them dextrose after that. If we give them dextrose first, we're essentially shunting those patients who may have alcohol involvement from pyruvate to the anaerobic pathway, which can actually make things worse because if you're generating lactate, that can develop an acidosis, particularly a metabolic acidosis, and make complications for your patient much worse. It can also promote what's called Wernicke's encephalopathy, which is an altered mental status associated with alcohol withdrawal. So it's important to realize that adults get thiamine first if they have a low blood glucose of 100 milligrams, then they get dextrose after. In addition to the stabilization phase, you want to get IV access because most likely if a patient has a seizure, you might be needing to administer an IV drug. You also want to collect labs such as electrolytes, hematology panel, tox screen, and if appropriate, again, anticonvulsant drug levels. Now, your patient has been seizing for a period of around 5 minutes or so. And remember, these time frames are not necessarily concrete for every patient. We may decide to treat them a little bit earlier. So what is essentially the therapy of choice at this point if you see a patient is seizing continually? And remember that 5-minute mark is essentially the mark where you may be considered status epilepticus. Well, we have essentially 3 first-line options, and those are intramuscular midazolam, IV lorazepam, or IV diazepam. You note that all of these routes are parenteral routes. So we'll talk about each of these drugs in the benzo category, which is first line for status epilepticus. All benzodiazepines, such as diazepam, are GABA agonist, as we've previously discussed in other lectures. And for status epilepticus, diazepam is available IV, IM, or rectally as a rectal kit. The status epilepticus dosing is 0.15 milligrams per kilo IV or IM, and a maximum per dose of 10 milligrams. And this number will be important for you to know. Any of the bolded dosing that you see here will be required for memorization purposes. Adverse effects of the benzodiazepines include hypotension and respiratory depression. Some considerations with diazepam specifically is that it rapidly redistributes. It has an active metabolite, and the IV formulation contains propylene glycol, which is essentially one of the excipients in the formulation, and this excipient can go on to cause a metabolic acidosis, as well as profound hypotension. So that's important to note, particularly if it's given over longer periods of time, which most of the time the diazepam doses are given as just boluses. One of the more used agents for status epilepticus is midazolam compared to diazepam, though diazepam can still be used. Again, it's a GABA agonist. For midazolam, it's available for status IV, IM, intranasally or IN, and buccally, or basically put in the cheek if you need it. But parenteral routes are preferred, particularly the IM route for midazolam. Its maximum per dose is 10 milligrams, also just like diazepam. Adverse effects are hypotension and respiratory depression. Like we've talked about before with midazolam, it rapidly redistributes. It has an active metabolite and is renally eliminated. So patients who have end-stage renal disease or AKI, you may be able to get away with 1 bolus dose of this agent. However, I probably would not recommend a drip of this agent for patients who have end-stage renal disease. And the last benzodiazepine, which is probably the preferred benzodiazepine of all the benzodiazepines, though for testing purposes, if you have a benzodiazepine listed, I'm not necessarily going to say one benzodiazepine is better than the other because you can use any of the 3 of them, is Lorazepam. It's also GABA agonist. It's available IV and IM, though the IV is the preferred route for administration. Its maximum per dose is 4 milligrams, so it's different than the other benzos in this talk, which have a maximum of 10 milligrams. Adverse effects include hypotension and respiratory depression. Considerations with lorazepam is that it has to be diluted 1-to-1 with saline, and that its IV formulation contains propylene glycol, which again can cause a metabolic acidosis and hypotension, particularly if given as continuous IV infusion. Here's just a comparison of the different benzos that we have available. I'm not going to hold you responsible necessarily for the onset of these benzos. That part is not necessarily important to know the exact minutes or the exact numbers. Duration is also not necessarily a need-to-know thing. All I would know is that lorazepam does last longer than midazolam or diazepam. That's the thing I would get from this. I don't want you to know exact numbers. The dosage forms, which are important for you to know. The max doses here, which I want you to know. And the adverse effects and the special considerations, which were on the previous slides. In regards to primary literature regarding the benzodiazepines and why we use benzodiazepines first line for status epilepticus compared to other anti-epileptic agents, the hallmark trial for this is essentially what's called the VA-COOP Trial, and it was titled Comparison of 4 Treatments for Generalized Convulsive Status Epilepticus. It's a multi-center, double-blind, randomized trial in adult patients. And we had 4 treatment groups in this study with about 570 patients total. So we had IV lorazepam, IV diazepam, then IV phenytoin in another group, IV phenobarbital, and IV phenytoin. And one of the goals that they looked at for their outcomes was abortion of seizure within 20 minutes with no recurrence prior to 60 minutes. And in regards to their outcome, they saw that IV lorazepam was superior to IV phenytoin, and that result was statistically significant, as well as superior. So that's why we will use benzodiazepines first compared to other agents, particularly with IV lorazepam being the preferred one, but again, if you saw diazepam or midazolam being used for status, I could not fault you for that. As long as it is being used at an appropriate dose. We want to make sure that we dose these agents appropriately such that we can abort the seizure, because dosing is very important. Another trial that was done was the RAMPART trial, which was the Rapid Anticonvulsant Medications Prior to Arrival trial, done in 2012. It was a multi-center, double-blind, randomized, non-inferiority trial in both adults and children. Compared IV lorazepam to IV lorazepam to IM midazolam, had 893 patients. And what their primary outcome was that they were looking for abortion of seizures without additional therapy at arrival into the ED. In regards to that outcome, 73% in the IM midazolam group versus 63% in the IV lorazepam group had abortion of seizures. What they determined in this study was that IM midazolam was both non-inferior and superior to that of IV lorazepam. Though, again, depending on what you have available at your institution, if you're treating status epilepticus, whether it's midazolam or lorazepam, you see that you have a significant success rate in either group here. And this study is a little bit debated in that there were a few potential weaknesses in the actual study that may limit the validity of these results, as with every study out there. So the RAMPART trial essentially compared IM midazolam to IV lorazepam. They found it was non-inferior and superior to. So for testing purposes, I would be familiar with these trials and the outcomes of these trials and what populations were studied, what was studied in regards to interventions, and the outcome data regarding that. Now, if you don't have any parenteral benzodiazepines available, like Diazepam, Lorazepam, or Midazolam, you can use some other agents in those agents' place, such as IV Phenobarbital. You can use the rectal version of Diazepam, or you can use intranasal or buccal Midazolam. So since Phenobarbital is the only agent we haven't talked about this far, we'll go over that agent very briefly. Phenobarb is considered a GABA agonist similar to the benzodiazepines and potentially an AMPA antagonist. Remember, AMPA is an excitatory receptor. So if you're antagonizing the AMPA receptor, you're essentially minimizing excitatory activity. Phenobarb is available IV for status epilepticus, and the dosing for that is 15 to 20 milligrams per kilogram. Again, it's important that you realize that this dose is not bolded, so I don't want you to know this dose for testing purposes. Adverse effects are hypotension and respiratory depression. And again, like some of our other benzodiazepine agents, IV formulation contains propylene glycol. Okay, now you've given your patient a benzodiazepine. And it may be, 10-15 minutes after the administration of that benzodiazepine. Remember, the onset is relatively quick in comparison of the benzodiazepines. However, your patient's seizure has still not cessed. You can give any of the following options: Fosphenytoin, Valproic acid, or Levetiracetam or Keppra as next-line therapy, in addition to Phenytoin, with Fosphenytoin being the prodrug of Phenytoin. It's important to note here that there's no evidence-based preferred second-line therapy of choice, and all of these drugs will have different mechanisms of action. In regards to Fosphenytoin, it's also known as Cerebyx. It's a prodrug of a voltage-gated sodium channel antagonist, i.e. Phenytoin, and it is available both IV and IM for administration versus Phenytoin, which is traditionally only IV, which we'll talk about on the next slide. It's important to note that Fosphenytoin has its own dosing units. It's dosed in Phenytoin equivalents, such that 1.5 milligrams of Fosphenytoin is equal to 1 milligram of Phenytoin. So it's essentially a 3-to-2 ratio here. So if you multiply Phenytoin doses by 1.5, you get Fosphenytoin. And as you see on the vial here, this is how they will actually label the dosing of Fosphenytoin. Now, for testing purposes, the Fosphenytoin dose has to be listed as milligrams of PE, or Fosphenytoin equivalents. For status epilepticus initial dosing, the initial dose is 20 milligrams of Fosphenytoin equivalents per kilogram, IV or IM. One of the benefits of giving the drug, specifically Fosphenytoin, is that it can be given IM if you don't have IV access yet. Adverse effects include hypotension, though one of the benefits of Fosphenytoin, because it is a prodrug of Phenytoin, is that the hypotension is actually less likely than Phenytoin. Phenytoin also contains, like some of the benzo agents in Phenobarb, propylene glycol as one of its excipients, and as a result of that propylene glycol containing substance, those agents are more likely to cause hypotension. Because Fosphenytoin does not have propylene glycol in it, it's less likely to cause hypotension, though it still may occur. Fosphenytoin may also predispose a patient to arrhythmias. Considerations are that it's compatible in normal saline, dextrose, or lactated ringers, in comparison to Phenytoin, which is only compatible in normal saline, which we'll talk about on the next slide. Phenytoin, which is not necessarily listed on your guideline list, however, is still used as a major second-line agent for status epilepticus. should be considered if Fosphenytoin is not available. Not every hospital or institution that you're at will have Fosphenytoin available, and one of the reasons for this is because of cost. So Fosphenytoin may not necessarily be on your formulary, and you may have to rely on Phenytoin instead. Phenytoin is a voltage-gated sodium channel antagonist. It's available only IV, not IM, for administration. For status epilepticus, the dosing is also 20 milligrams per kilo IV. Remember, this bolded dosing here is dosing you're responsible for. Its adverse effects include hypotension, arrhythmias, and what's known as purple glove syndrome, particularly if it's administered in peripheral lines. Ideally, patients should get a central line or central IV line to administer Phenytoin, so that you can minimize the risk of what's known as purple glove syndrome, which essentially just means a purpling of the hands as a result of the infusion of Phenytoin in a small peripheral line. Some considerations with Phenytoin are that it's compatible in normal saline only, and again, the IV formulation contains propylene glycol, which can predispose a patient to metabolic acidosis when given continuously, as well as other things such as hypotension, which this propylene glycol can also cause. So whenever patients are receiving the initial dose of Phenytoin IV, it may be given over a longer period of time to try to minimize that hypotension risk. Phenytoin is very notorious for causing hypotension when administered IV. So in some cases, Phenytoin doses may be administered over an entire hour up to, depending on the dose of Phenytoin that's administered. Another second-line agent is valproic acid or Depacon. Valproic acid for status enhances GABA action. For status, it's available IV, and for the status dosing, it is available for between 20 to 40 milligrams per kilo IV. Again, you see that number 20 is a recurring theme in this second line of drugs. So adverse effects of valproic acid are hyperammonemia, so you might not want to give this to a patient that has a high ammonia level. These high ammonia levels can be toxic, as we briefly discussed with the inborn errors of metabolism earlier. Valproic acid can also predispose patients to develop or worsen pancreatitis. Valproic acid may cause thrombocytopenia or hepatotoxicity. Some considerations with valproic acid is that there is a caution in traumatic brain injury patients, and it may be preferred for glioblastoma multiforme, which is a type of tumor, particularly of the brain. The last second-line agent is Levetiracetam or Keppra. It inhibits the SV2A glycoprotein and presynaptic calcium channels. For status epilepticus, the primary route is parenteral, like all of the other agents, so ideally IV, though there is a PO disintegrating tablet that is available. Initial dose for status is between 20 to 60 milligrams per IV. The maximum per dose is a little bit debated. In some sources I've seen in practice, most of the time I've seen a maximum of 3 grams given at any one time, though some sources say that you can go up to 4,500 milligrams. As long as it fits within this range, it's probably good to go. I would probably start out with 20 milligrams per kilo myself. Most doses I've seen range between 2 grams and 2.5 grams, depending on the patient's weight. Some adverse effects are hypotension and hypertension, though the hypotension does not happen very often compared to agents such as Phenytoin. Some considerations: Keppra is a relatively new agent, and it has minimal drug interactions, and it's not hepatically metabolized. Therefore, you can give it in patients who have hepatotoxicity. So what happens if none of the previous options are available for first or second line treatment? You can try IV phenobarb again. Remember, it's an alternative agent for both first line and second line per the algorithm earlier. You can potentially redose benzodiazepines. You may give another agent like a continuous infusion agent, which we'll talk about, or you may give a newer agent because there are newer agents that are coming out to potentially treat status epilepticus and epilepsy in general. So it's really debatable after the first line therapy, as we saw with the different studies that were available with first line therapy, such as RAMPART and VA-COOP, where we have strong evidence that says benzodiazepines should be used first. With the second line therapy, you note I didn't include any landmark studies because there's limited data regarding this. And now that we're getting to third line therapy at this point, there's even more limited data regarding what you should do next. So any of these options are viable options after second line therapy. But obviously, you have to check the patient's benefit and risk of receiving those agents, because some agents may be cautioned or contraindicated in certain patient populations. So, in regards to third line therapy, typically third line therapy can be instituted in a ballpark range of 40 to 60 minutes after the seizure begins. Though it may actually occur earlier depending on if you have patients set up for intubation, because you'll see that a lot of the third line therapies actually are anesthetic agents and require mechanical ventilation and intubation. Like we mentioned, third line therapy for status epilepticus lacks strong data in the literature. Should you redose a previous first or second line therapy? It's debatable. Should you use another agent? Again, it's debatable. You could do that. That's perfectly fine. But if you see that the status epilepticus is essentially refractory to pharmacological agents such as a benzodiazepine or any of the second line agents, you may consider a third line agent for treatment of what is called refractory status epilepticus. As we mentioned earlier, refractory status epilepticus means that your seizure has been prolonged, and some people will say for 30 minutes, or you've received multiple agents previously, so 2 or more for status epilepticus. In regards to the agents that we can use for third line therapy, other than the ones we've previously talked about, you can use anesthetics such as continuous, midazolam, propofol, pentobarbital, or if you're abroad and have thiopental available, you can also use that as well, though it's not available in the U.S. So, in regards to status, third line therapy consists of these 3 agents in the U.S., midazolam, pentobarbital, or propofol. Again, midazolam, GABA agonist. You see the dosing here for initial dosing and then continuous infusion dosing. The continuous infusion dosing, I don't expect you to know. This dosing here can be used as bolus dosing. Again, the dose I want you to know for midazolam is 10 milligrams max for the initial dose. And here, you can increase the rate depending on need for response or cessation of seizures by 0.05 to 0.1 mg per kilo per hour every 3 to 4 hours. Some considerations with midazolam is that you may develop tachyphylaxis with prolonged usage. Tachyphylaxis just means essentially your body essentially is developing tolerance for the dose, and you may need higher doses. Again, it has an active metabolite. It's renally eliminated, so it may not be the best thing to give as continuous infusion for ESRD or AKI. Rapid redistribution, and again, continuous infusion requires mechanical ventilation. Propofol, or Diprovan, as we talked about with the the sedation and paralytics talk, GABA agonist and NMDA antagonist potentially. Initial dosing for a bolus dose is 1 to 2 milligrams per kilo. And then you see the continuous infusion dosing here is dosed in micrograms per kilo per minute IV. And then you can increase the rate as needed for response to status. So say if your status is not resolving, you can increase the rate of this agent. Adverse effects, as we mentioned before, hypotension, respiratory depression, cardiac failure, rhabdomyolysis, metabolic acidosis, which the metabolic acidosis and some of the other organ failure symptoms are commonly associated with propofol-related infusion syndrome. And I probably shouldn't say commonly associated with. Propofol-related infusion syndrome doesn't happen very often because people are very cognizant of it. Again, propofol-related infusion syndrome commonly happens when the dose of propofol that you're being administered is very high, and for prolonged periods of time, such as that of greater than 48 hours. Doesn't necessarily mean it will occur in everyone, but it's something to be aware about because it is a lethal syndrome that can occur as a result of propofol administration. Again, with propofol, requires mechanical ventilation for a continuous infusion. And again, it is contained as a lipid emulsion, which contains 1.1 kilocalories per ml. So that's very important to note. And then the last agent in this category is pentobarbital. Also, when used, is known as pentobarbital coma. Pentobarbital, for status purposes, is a GABA agonist and an AMPA antagonist. For status dosing, you can give a bolus of 5 to 15 mg per kilo and then a continuous infusion thereafter. And then you can increase the rate of the infusion depending on your response to the status. Some adverse effects of pentobarbital are hypotension, respiratory depression, cardiac depression, paralytic ileus. Ileus just means a non-movement of the bowels, or essentially bowel not being able to function properly. A loss of neurological function may occur as a result of pentobarbital. Typically, this agent's reserved last line or third line for status epilepticus. Some considerations is that this agent, while given continuous infusion, requires mechanical ventilation. And again, this agent contains propylene glycol, which we've already discussed with some of the other agents. Okay, so now you've instituted all of these agents at the same time, potentially, on some of these agents for status epilepticus, but your seizure is not succeeding. So what do you do once you're past your third phase of therapy and you're giving a continuous infusion? You have potentially some other treatment options that you can take a look at as well. And those include lacosamide or Vimpat, topiramate, ketamine, lidocaine, immunomodulation, and non-pharmacological therapy. We're not going to talk about all of these, but we will focus on just three: lacosamide, ketamine, and non-pharmacological therapy, as these agents are probably some of the more commonly seen out in practice. Topiramate can be used, but I haven't seen it much in clinical practice. I haven't seen lidocaine at all be used for status, nor have I seen immunomodulation be used. But these are options out there that are available, and it's important just to be aware about them, that they're there. In regards to lacosamide specifically, or Vimpat, its mechanism is to slow inactivation of voltage-gated sodium channels. This agent is available IV for status epilepticus, and it also has a PO version for maintenance therapy. For status epilepticus dosing, the dose is 200 to 400 milligrams IV bolus. The dosing that you may see for PO may be 100 milligrams, so that's important to note that the dosing is slightly different for status epilepticus dosing. Some adverse effects of lacosamide, as Dr. Wang probably talked to you a little bit, is the PR interval prolongation. Vimpat can also cause hypotension, though this is not seen as commonly as with agents like Phenytoin when given as IV infusion. Some considerations with lacosamide is that it has minimal drug interactions and it has limited data with status epilepticus. So if you see this as a choice on an exam, for an example, and you have another agent that has more data behind its use versus lacosamide, I would probably pick the other agent. Doesn't mean that you can't use lacosamide, but whenever you're trying to balance the benefits and risk, the benefit is questionable at this point because lacosamide is a newer anti-epileptic agent released probably, I believe, within the last 10 years. So it doesn't have as much data actually behind it compared to a lot of the other agents like benzodiazepines, which do. And then ketamine is another agent that can be used for status epilepticus. As we talked about with the sedation talk, ketamine is an NMDA receptor antagonist, so minimizing the excitatory activity. It's available IV for status and traditionally is given as a continuous infusion. For status epilepticus, the dose has to be at least 0.9 milligrams per kilo per hour, which has been found in some studies to be most efficacious in termination of status epilepticus. Again, adverse effects of ketamine: psychosis, neurotoxicity, neuronal loss, hypertension or hypotension. Again, the hypotension is not as frequent as phenytoin. And then considerations for ketamine: if you're giving an IV continuous infusion, it needs to be under mechanical ventilation for the patient. It can increase ICP or intracranial pressure, so it may not be the best agent to give in the case of traumatic brain injury. And again, like lacosamide, it has limited data with status epilepticus. Not necessarily because it's newer, but because there has not been many studies done on it. And typically, by the time you get to using ketamine as an option, it's typically used in a third or fourth line type of situation. And whenever you get into those situations, it's hard to do studies regarding the use of ketamine in a randomized controlled fashion, since a lot of your factors are going to be different between patients and treatments. Okay, so now your patient potentially may have a resolution of their status epilepticus. How do you de-escalate all of this pharmacotherapy that they're on? Because at this point, they may be on an anesthetic agent like midazolam, propofol, pentobarbital, or even ketamine, and as well as some other maintenance agents. So they may be on scheduled IV phenytoin, Keppra, valproic acid. Heck, they may be even on Vimpat or lacosamide scheduled, as well as, getting periodic boluses of benzodiazepines. How do you de-escalate this pharmacotherapy? Well, the first thing you want to do is you want to determine the original etiology and treat the original etiology of the seizure if possible. And you want to plan ahead for therapy de-escalation. So you want to ideally have a plan in place to say which one you're going to take off first and have rationale why. And an EEG may assist in determining which of the agents that the patient's on is actually effective. So whenever a physician, like a neurologist, will be interpreting an EEG and they see burst suppression occur, what they may start doing after about 24 to 48 hours of burst suppression is trying to lighten the sedatives or anesthetic agents, or even take some of the other agents off. Now, if your patient does not respond well to this and then has another seizure occur, then you may put that agent back on. It all depends on the interpretation of the EEG. So you may go with a strategy where you lighten sedation or anesthetics after 24 to 48 hours of burst suppression. Another important thing to do is, if you're trying to get them off of a sedative drip or an anesthetic drip, is you may want to increase the maintenance doses of your anti-epileptic agents that are being used scheduled-wise, such as like phenytoin or valproic acid, to therapeutic or even supratherapeutic levels while the anesthetics are being tapered off. because if you taper off an anesthetic, the patient may be more prone to developing a seizure while that anesthetic is being tapered off. What you can do for phenytoin is titrate it to a level potentially that's super therapeutic, such as 20 to 25, or for valproic acid, that level would be between 100 and 150. Remember, 50 to 100 for valproic acid is therapeutic. For phenytoin, it's traditionally 10 to 20. So for phenytoin, you can titrate up to 25, or for valproic acid up to 150. And that may help in the short term to essentially keep get your patient off of sedation or anesthetics. Now, those super therapeutic levels are not maintained for the complete duration of the patient's phenytoin or valproic acid therapy, for example. Those levels are done in the acute phase and completely monitored consistently in the short term, at least while the patient may be resolving in their status epilepticus in the hospital. Those super therapeutic levels should not be maintained upon discharge. In regards to non-pharmacological treatment of status epilepticus, some things that can be done include vagal nerve stimulation. Another thing that can be done as a ketogenic diet, which Dr. Wang probably talked to you about in the epilepsy talk the previous week. Hypothermia may be potentially induced in some patients. Electroconvulsive therapy may also be done. So essentially what they do in electroconvulsive therapy is they hook them up to a machine and generate convulsions into the patient to try to cessate any epileptic activity that may be occurring on EEG. And this can also be used in some other psychiatric disorders, which Dr. Wang will talk with you about later in the semester. Transcranial magnetic stimulation and surgical management. So it's not necessarily important to be an expert at each of these different non-pharmacological treatments. The treatment for status epilepticus, as we've seen first line, is traditionally a pharmacological agent, which is a little bit a reverse in logic from other disease states where we want to do non-pharmacological therapy first. These things can be potentially done on the outpatient side, most likely, with exception of the hypothermia or surgical management. There are some specific considerations that you should take a look at in selected patient populations, and some of those patient populations include pregnancy, pediatrics, geriatrics, and anoxic brain injury. So regarding status epilepticus in pregnancy, it's always important to determine the risk versus benefit for the patient as well as the child. In regards to status epilepticus in pregnancy, the use of teratogenic medications may be acceptable acutely in patients who are pregnant. So even if it has a pregnancy category of X or D, and your patient is presenting to you in status, you have to outweigh the risk and you have to weigh the risk and the benefit. The benefit obviously is to cessate the status epilepticus, but the risk also may potentially be a harm to the child that is growing inside the mother's womb. And in some cases, you may actually just have to give the agent to try to get rid of the seizure, which can cause damage to both the mother and the child. Now, whenever the patient is out of status epilepticus, you may consider alternative medications for maintenance therapy that don't have a pregnancy category of X or D. And ideally, you want to consider agents that likely have a pregnancy category of A or B. You also may have altered pharmacokinetics in pregnancy, which can affect dosing of many drugs. You do have a higher volume of distribution, so you actually may need an elevated dose of drug in pregnancy, and you also have increased clearance in pregnancy for some drugs, which can affect dosing. In regards to pediatrics, pediatrics have a very similar treatment approach compared to adults. In regards to pediatric patients, doses are weight-based, and some of these doses may even be higher than doses compared to some adult patients. In regards to pediatric patients, you may consider the use of IV pyridoxine when pediatric patients present, though it's not necessarily mandatory. Again, you want to remember what the etiology of the seizure is and treat the etiology of the seizure. So if your patient comes in hypoglycemic, you want to treat the hypoglycemia with dextrose. But again, the first line therapy is benzodiazepines. The reason why we would consider IV pyridoxine specifically, pyridoxine being vitamin B6, is that some pediatric patients may have a deficiency in vitamin B6, and that may cause them to seize. So you may consider IV pyridoxine in some of these pediatric patients. And whenever you actually evaluate the benefit and risk, IV vitamin B6 may not have as much risk to the patient. In regards to pediatric patients, because patients may have, or practitioners may have trouble trying to obtain IV access on pediatric patients, relating to the size of the patient as well as the smaller vasculature of pediatric patients, you may consider alternative routes of drug administration in these patient populations, such as intranasal, buccal, rectal, or intramuscular administration of drugs, if intramuscular administration of drugs can be done for those specific medications. In regards to geriatric patients, and for our purposes, I consider geriatric patients above the age of 65, though some clinicians may have a lower threshold for that age cutoff. It's important to investigate drug-induced and disease state-induced status epilepticus. In regards to treating status epilepticus, some geriatric patients may have more adverse effects associated from status epilepticus medications. So if you're giving them a benzodiazepine or a sedative agent or an anesthetic agent, these geriatric patients may have more risk of sedation or a higher level of sedation, as well as cardiorespiratory adverse effects. So decreased respiratory rate. To combat these adverse effects, medications may be infused more slowly to minimize these. And it's also important to consider the elimination of these drugs, because patients who are geriatric may not have as good of kidneys as a healthy younger patient may have. So in those cases, you may have to dose adjust some medication doses if the patient has a renal failure or hepatic failure. And I'll let you look up which drugs actually that applies to. One of them, particularly for renal failure that we might consider dose reducing, is Keppra or Levetiracetam. Though that's not the only agent that would need to be renally adjusted. Midazolam may also need to be adjusted as well if given continuous infusion. For patients that have anoxic brain injury, so brain injury as a result of not getting enough oxygen, these patients generally have a poor diagnosis, and you may consider hypothermia for these patients, similar to what we do in patients who are post-cardiac arrest, to try to minimize the neurological implications and the neurological morbidity associated with the injury. So hopefully you may preserve some brain function as a result of doing hypothermia, though there's limited data with this. In regards to future directions of how to treat status epilepticus, there's a trial currently being done called the ESET trial, which is evaluating second-line agents for status epilepticus, such as Fosphenytoin, Levetiracetam, and Valproic acid. This trial is currently being done and is still currently, as of recording of this lecture, still recruiting patients. And ideally what they're going to try to look at is the efficacy and as well as potentially adverse effects associated with these agents when used as second-line therapy for status epilepticus. So it's an important trial to be aware of, currently still in progress. Other directions would be more cost-effective treatment approaches for status epilepticus. As we mentioned, some of these agents may be more expensive, like Fosphenytoin. Also, effective extended EEG monitoring, potentially even after status epilepticus has resolved for even a couple of days or even past that, is being investigated. And then early use of anesthetics and optimal duration of therapy is also being evaluated currently. So maybe use of anesthetics as first or second line therapy. More so probably second line therapy, because we would probably want to give a bolus dose first of a benzodiazepine versus using an anesthetic agent. However, that is something that's currently being analyzed in the pipeline right now. In regards to status, this is essentially the proposed algorithm for convulsive status epilepticus that we've gone over today. This algorithm can also be applied to non-convulsive status epilepticus, assuming that you have an EEG monitor and you see status epilepticus pop up, or status epilepticus activity interpreted from the EEG by a neurologist. So this doesn't necessarily just apply to convulsive status epilepticus, it can also apply to non-convulsive status epilepticus. Which, in any event, the treatment choices are outlined here for you. Again, the time frame here is not as important to know about. It's more important to know about the sequence of what you actually do in status. Here are the references for this talk. And we're going to go back to the patient case. So we had AI, an 80-year-old male, presenting to the ED with altered mental status. After about 2 minutes in the ED, he develops a visible, uncontrolled, generalized convulsive seizure that lasts for at least 5 minutes. He has no relevant past medical history. Which of the following is a first-line pharmacotherapeutic agent that can treat AI seizure? Answer here is Lorazepam. Now remember, we talked regarding first-line therapy that benzodiazepines are preferred agent for the treatment of status epilepticus, as demonstrated by the VA-COOP Trial. So therefore, because Phenytoin, Levetiracetam, and Valproic acid are not benzodiazepines, they are not the correct answer for first-line treatment. Second question, AI was provided first-line pharmacotherapy to treat a seizure in question 1 with the benzodiazepine. However, a seizure did not resolve. The healthcare team decides to give another agent to abort AI's seizure. 15 minutes into infusion of the second treatment, AI's blood pressure drops drastically to 70/46. If chosen as treatment, which of the following pharmacotherapeutic options is most likely to cause hypotension? The answer here is Phenytoin. And as we talked about, one of the big reasons that Phenytoin may cause the hypotension is because of its propylene glycol content. Fosphenytoin doesn't cause as much hypotension in relation to Phenytoin because it doesn't have propylene glycol in it. Levetiracetam can cause hypotension, though it's not to the level of Phenytoin, and valproic acid traditionally does not cause hypotension in patients who receive it. So Phenytoin here is the correct answer. If it was given as a second-line agent and hypotension developed, it would probably be related to Phenytoin or another agent that would cause hypotension. And the last question, despite treating AI with 2 abortive medications, AI is still seizing. It has been 30 minutes since the beginning of his seizure. Which of the following types of status epilepticus does AI have? And the answer here is refractory. Now, in regards to refractory typically refers to status epilepticus that has not resolved after multiple pharmacotherapeutic agents, or a prolonged status epilepticus duration, which some people would define as 30 minutes. Some clinicians may define refractory status epilepticus even occurring after you've treated with one medication and it hasn't resolved. The definition is very debatable. However, if you're treating traditionally with multiple abortive medications, so 2 or more, and it's been at least 30 minutes, most clinicians will consider that refractory. This patient did have convulsions, so if they had only received one abortive therapy or no abortive therapy at that point, and it had been maybe 5 minutes, you can consider it generalized convulsive. Non-convulsive, we said, was associated with no convulsions. And then we don't know necessarily at this point if AI actually has epilepsy. His past medical history was not pertinent to this case. However, if his seizure activity continues and it is repetitive, he may be diagnosed with epilepsy at a later time. If you have any questions, please feel free to email me. Thank you and have a good day.